Jeff, I think we're going to start. Thank you all for coming. We are going to give just a brief, this is a very special grand round, so we are excited to have Dr. Paris Butler. I'm going to give an introduction of Dr. Butler shortly, but we wanted to give just some history behind the naming of this grand rounds in honor of Dr. Walter Scott Brown. An email was sent to you, to the department detailing this. We wanted to just take a moment to honor this amazing surgeon and set some context for the amazing grand rounds lecture that we're going to receive this morning. So thank you so much, Dr. Preacher.
Morning, everybody. I first learned about Dr. Walter Scott Brown through some work that Dr. Butler, our speaker today, presented at the American Society of Plastic Surgeons, and that set off a sort of quest of ours in the Division of Plastic Surgery to learn more about him and to ultimately honor him. So I have a little blurb here that I'd like to talk to you about to explain the significance of Dr. Brown. So he was, Dr. Walter Scott Brown was a pioneering figure in the world of plastic surgery, not only in the Seattle area, but in the realm, the community of Black plastic surgeons in the United States, excuse me. He was born in Alabama and obtained his medical degree from the University of Illinois back in 1931. And following that, he accepted an internship here in Seattle at Providence Hospital, which is now Swedish Cherry Hill. After training, he worked as a general practitioner while performing some surgical procedures, and then World War II broke out, and he volunteered for and was commissioned in the Army as a physician in the Army. And it was during that time he learned about plastic surgery techniques such as flaps and dermabrasion. So at the conclusion of his commission, he returned here to Seattle and began incorporating plastic surgery procedures into his practice. With time, his work became almost entirely composed of reconstructive operations, and he later delved into aesthetic plastic surgery procedures. Reportedly, the results of his aesthetic procedures were pretty noticeable, shall we say, not subtle. But as best we can discern, Dr. Brown was likely not only the first Black plastic surgeon in the Seattle area, but the first plastic surgeon of any ethnicity to practice our specialty here. At one point during his career, Dr. Brown was able to design and build his own office with an operating room, and that building still stands next to Harborview across from the ambulance bay. You may notice that it has a 3-car garage in the back of it, and that was for his classic car collection. He became a prolific teacher of plastic surgery, working with surgical trainees, and later had a clinical teaching appointment as associate professor here at the University of Washington in the Department of Surgery. Notably, he was asked to come on full-time to the University of Washington, but when the then chair of the department would not guarantee employment for his 3 nurses, he declined. So Dr. Brown was generous with his time and funds, teaching surgical trainees and endowing scholarships at Seattle University and the University of Illinois. He was able to join some national plastic surgery organizations, but not others due to discriminatory membership rules. And he was a friend to many, and by all accounts, a generally fascinating person. So in recognition of his contributions to the University of Washington Department of Surgery, the Seattle plastic surgery community, and the community of Black plastic surgeons across the country, we've designated this Diversity Council event the Dr. Walter Scott Brown Diversity Grand Rounds. Furthermore, we're excited in the Division of Plastic Surgery at the University of Washington that we have established an award in his honor. This award will enable one plastic surgery resident yearly to attend a National Surgical Society conference that aligns with their self-identification. And this award will enable residents to connect with their national communities, something that we believe Dr. Brown would wholeheartedly endorse. Thanks very much.
So I appreciate, thank you so much, Dr. Friedrich, for bringing some history and context into this grand rounds. And I think it's always important to understand the foundations, right? We always remember our surgical giants, the shoulders on which we stand. And in this Black History Month, any identity that you carry, it's always important to remember those giants from which we stand. And it's something that I take to heart every day and appreciate that ability to bring that here and share with you all today. So thank you. And I also want to take this moment to thank Dr. Butler. I have the honor of introducing him as a colleague and I hope as a friend. And I think Dr. Butler has, I take that back. I know Dr. Butler has been an inspiration to so many, countless students, residents, junior faculty, myself, in the way in which he is able to not only instills excellence, academic excellence into surgery and the profession of surgery, but into any and everything that he touches. And that is felt in the way in which he is able to kind of rally the troops and get so many people both behind him, but also in front of him, propelling careers forward. And that is something that not many have the talent to do. So it's my immense honor in recognizing and having him here. And thank you for gracing us with your presence and your words of wisdom that you'll impart. Dr. Butler is an associate professor in the Division of Plastic Surgery at Yale School of Medicine, and he is also the inaugural Yale Department of Surgery Vice Chair of Diversity, Equity, and Inclusion, board certified by the American Board of Surgery and the American Board of Plastic Surgery, and a fellow of the American College of Surgeons. Please give a warm welcome to Dr. Pierce Butler.
Good morning. Thank you for that kind introduction, Dr. Williams. Also, thank you very much, Dr. Williams, Dr. Quiroga, Dr. Wood, Dr. Vetter, Dr. Friedrich, Dr. Dick, for inviting me. Thank you for treating me like one of your own for the last day and a half. I'm a Southern boy, and this Southern hospitality that I felt here in the Pacific Northwest goes a long way with me, so I greatly appreciate it. Dr. Williams and I started having this conversation about me coming out to Seattle almost a year ago. And I was excited then. And about 2 months ago, Dr. Friedrich very kindly reached out to me and said, Paris, what do you think if at your grand rounds, we announce a scholarship in honor of Dr. Walter Scott Brown? And I embarked on this project about a year and a half ago with one of my mentees who's getting a master's degree in medical history, a gentleman by the name of Joshua Glan. He wanted to do his thesis on contextualizing and recognizing the history and the contributions of Black plastic surgeons in organized plastic and reconstructive surgery. And we presented this data at PSTM, as Dr. Friedrich very kindly stated. And when he said that they were going to name a scholarship and they were also going to name this lectureship in his honor, I was just absolutely overjoyed and got goosebumps as I was sitting listening to the introduction of the scholarship. So thank you for that. I thank you to your department for embracing that. And I can't help but say a couple things about Dr. Brown. Now, I won't reiterate, and I'm hoping that everybody reads this. I think this is, for my residents, this is manual reading, particularly in Black History Month, mandatory reading in Black History Month. So couple things pertaining to Dr. Brown. 3 things really stick out to me. And one of them is the final one's a segue into my talk this morning. So Dr. Brown actually is legacy physician. So Dr. Brown's father, the original Dr. Brown, actually graduated from medical school in 1891. Now, it's very uncommon for gentlemen of his seasoned age and for Black physicians or for Black people to get medical degrees in 1891. But the first Black person to get a degree in the United States, the medical degree in the United States of America, was Dr. Peck Rush in 1847. The first woman to get a medical degree in the United States was Dr. Blackwell, as many of you know, a year later in 1848. But anyway, the original Dr. Brown knew that his son had quote unquote what it takes to become a physician. So after graduating from Talladega College in Alabama, which is where the original Dr. Brown practiced after leaving the University of Michigan, he sent his son to the more progressive North and Midwest in order to get his medical degree at the University of Illinois. He actually, the original Dr. Brown had a friend that was a pharmacist in Illinois, and the younger Dr. Brown had to stay with that pharmacist as he was applying for medical school. So the foresight that a father had of his son in order to put Dr. Brown in position, which we are all benefiting from because of what this Dr. Brown has gone on to do, I think speaks volumes. The second is that Dr. Brown was a golfer. I like golf. Dr. Brown was not very good at golf. I'm not very good at golf. Dr. Brown had custom clubs. Dr. Friedrich commented about his classic cars. And he was so generous with his resources at various country clubs around. I think he had memberships at 3 different country clubs in the greater Seattle area, which also speaks to the progressiveness of the greater Seattle area as it pertains to golf and country clubs and how that has historically looked. They've actually named the flagpole behind the 9th hole at Englewood Country Club in Dr. Brown's honor. And then third and finally, which is a segue into my talk, Dr. Brown, as you know, had started his practice. He volunteered for World War II to be a physician in World War II. At that time, World War I and World War II, the Army was still segregated. And Dr. Brown became a physician in the Army because he wanted to take care of patients at large, agnostic of race, ethnicity, didn't want to just take care of Black soldiers. Somehow, some way, Dr. Brown established a relationship with Franklin Delano Roosevelt's wife, Eleanor Roosevelt. And through a series of correspondence, and we actually found the letters, he wrote a letter to Eleanor Roosevelt saying that he had lived the majority of his life white, and he did not want to be subjugated to just taking care of Black soldiers because he thought his skill set transcended race. And lo and behold, Franklin Delano Roosevelt commissioned Dr. Brown to be able to take care of patients agnostic of race and ethnicity. He learned those skills like many plastic surgeons that I benefit from. He learned his skill set in World War II, which is what obviously he brought to the greater Seattle area, as Dr. Friedrich articulated. So I want you all to know that I have to believe, after spending a day and a half here, that Dr. Brown's legacy lives within the confines of the walls of University of Washington. Additionally, his legacy lives along with me. There are about 25 to 30 Black surgeons that hold faculty appointments in plastic surgery in the United States. And for sure, he has served as a mirroring opportunity for me in order to continue to pursue what I love as an academic plastic and reconstructive surgeon. So with that, I will get into my talk. So the title of my talk, Enhancing Ethnic Diversity of the Academic Surgical Workforce. What I'd like to say, reclaiming the narrative. I don't have any financial disclosures. I'm very proudly one of the directors of the American Board of Surgery, but these are my personal thoughts. This is not from the board, although I do my best to convince the board that we need to push on diversity, equity, and inclusion all the time, very unapologetically. So I had the privilege, between my general surgery training and my plastic surgery training, I was tapped to be a finalist for the White House Fellowship. And so Dr. Saletti very kindly allowed me to defer my plastic surgery training at the University of Pennsylvania so I could go be a policy fellow. So I served as a policy fellow in the Department of Health and Human Services during the Obama administration. And my primary portfolio item was to help unroll this new Affordable Care Act in underserved communities. And every day that I would go to the HHS building in DC, I would walk past this wall that had this statement, this placard on the wall from former HHS Secretary, Dr. Shalala. I'm going to read it out loud, not because I'm questioning your literacy, but it does absolutely set the tone for the next 40 minutes of my talk. So it says that we cannot have first-class universities without diverse student bodies and staffs. We have got to convince faculty members that what is at stake is the quality of the university, that you cannot have excellence without diversity. We have to make an educational argument, not a moral one. And if a large segment of the country does not have a first-class education, the health of the country is at stake. So diversity, equity, and inclusion, we know, is under siege right now. The fact that I know by first name at Yale, the Office of General Counsel, speaks to the fact that DEI is currently being vilified. And I think it is incumbent upon us to reclaim the narrative. So this is not just a social justice or charitable contribution issue. This is not about identity quotas. This is not about lowering standards. This is an issue of quality and excellence in surgical care. This was all rooted, diversity, equity, and inclusion, particularly in the health space, was all rooted in the alleviation and mitigation of healthcare disparities along racial and ethnic lines. That's where it's rooted, and that's where we need to make sure that we stand. So I had the privilege of serving on a panel most recently this past fall at the American College of Surgeons Clinical Congress pertaining to DEI and anti-racism fundamentals. And on the panel was this gentleman here. So I think it is absolutely necessary to have folks from the majority community that serve on these panels to have these hard conversations about diversity, equity, and inclusion. This gentleman here, Dr. Dan Dent, 6'7", Texan, who I've been on panels with in the past, who's absolutely an ally for diversity, equity, and inclusion efforts. I remember him getting a question from the audience pertaining to how do we do our best to reach those that are naysayers, pertaining to DEI. And he had a quote that will stick with me. And he said, try to keep the conversation centered around the patients. All of us, agnostic of gender, race, ethnicity, or sexual orientation, we are obligated to care for these patients, period. Again, centering it back to patient care, centering it back to the alleviation of healthcare disparities. So there is a growing consensus that in order to alleviate healthcare disparities is going to require a multifaceted approach. Improving access to care, improving culture of humility among providers, increasing public health funding, having more targeted research in minority-specific issues. And then one of those levers, just one of those levers, an important lever, but one of those levers, and the topic of my conversation, is increasing diversity of the healthcare workforce. So over the next few minutes, I'm going to basically provide some oversight, an overview of the racial and ethnic demographics of the U.S. academic surgical workforce. I'm going to discuss the why, as my wife likes to say, discuss the why it's important to have a more ethnically diverse surgical workforce. And then I'm going to provide some recommendations for how I believe we can improve this systemic challenge. So, as many of you know, surgery has been comprised of a rather homogeneous incumbent that doesn't necessarily reflect the patient population that we're blessed to treat. So this is from 1939, a picture of the first annual meeting of the American Board of Surgery. Those are the directors. 2 years later, the American Board of Plastic Surgery was instituted. This is a picture from then, and you can see there are no women and there are no surgeons of color. So what does it look like today in academic surgery? So vernacular is important and it's ever evolving. The terminology URM has kind of fallen out of favor. The AAMC recognized the fact that not all minority groups in the United States are actually underrepresented in medicine. So the term in 2010, actually, by the AAMC of underrepresented in medicine came into being. They recognize underrepresented in medicine as those that self-identify as Black, African American, Hispanic, Latino, or those that come from indigenous backgrounds. You can see here the blue bar is the representation throughout the United States using US Census Bureau data. You can see that the orange bar are a representation of US surgical faculty. Whites comprise 54% of the US population, but 74% of the faculty. Asians, 5.6% of the population, 10.8% of our faculty. Latinos, 18.3% of the population, but just 3.6% of our faculty. Blacks or African Americans, 12.5%, a little over 12.5% of the US demographic, but just 3% of our academic faculty. And then those that come from indigenous backgrounds, 0.4% and 1.4%. This is not just a surgical challenge. Agnostic of specialty, representation of African Americans and Latinos, particularly in faculty throughout the United States, is abysmal. You can see here, unfortunately, though, surgery tends to lag furthest behind, and my beloved plastic and reconstructive surgery is even further behind. Now, I spent a lot of time looking at the academic surgical workforce, not the surgical workforce at large. And in my opinion, so one, I think I've got the greatest job in the world, but two, we serve the triple threat, right? It's our responsibility to care for patients at a high level. It's our responsibility to carry the field forward with research endeavors. It's our responsibility to teach and mentor the next generation of physicians. And it's also our responsibility to serve as gatekeepers. I serve on 3 different search committees in different capacities. And I will tell you that responsibility is something that I don't take lightly. And is why I think that as we are talking about how we diversify the workforce, it really starts in academia. This graph is just a depiction of the fact that along each step towards a career in academic surgery, minority representation declines, and that's even among my Asian American colleagues. So you can see here, the light blue is our representation of medical students. The fuchsia is surgical residents. The cream is our surgical faculty representation. And then the light blue is our full professors. And you can see for whites, there's a steady increase in representation. And for Asians, Black, and Latinos, it's a steady decrease. When you take it another level and you look at academic surgery leadership, this was a paper that we published in 2020. On the left side, you see female representation of chairs. So the AAMC currently recognizes 154 departments of surgery in the United States. And with the block with the small white dots, in 2008, women only comprised 2% of the chairs of surgery in the country. Fast forward to 2020, and that jumped up to about 13.2%. So we're not where we need to be, but some strides have been made as it pertains to gender representation. Again, not enough, but some strides have been made. When you look at Black representation as it pertains to chairs of departments of surgery in the country, you can see here in 2008, Black surgeons comprised 8% of the chairs. Unfortunately, it's gone in the opposite direction. In 2020, Black surgeons only comprised 4.5% of Department of Surgery chairs. And then unfortunately, when you look at my beloved plastic and reconstructive surgery, you can name the number of Black and Latino chiefs or chairs of plastic surgery on one hand. So there's 101 training programs in the United States as it pertains to plastic and reconstructive surgery. And there are only 5 Black or Latino chiefs or chairs in the country. So Ed Rodriguez at NYU, Jorge De La Torre at UAB, Jifa Pazzo at Albany, she was just named a year and a half ago, Carrie Woodbury at West Virginia University, and Milton Armstrong, who's the director of the board. He's actually the first African-American to serve as a director of the American Board of Plastic Surgery at MUSC. Unfortunately, Dr. Armstrong is stepping down from his position this summer, so that will leave 4 unless they replace him with a Black or Latino surgeon. So the why. Why is ethnic diversification of the surgical medical workforce important? First and foremost, because healthcare disparities persist in the field. So every specialty under the surgical umbrella or medical umbrella has documented evidence of racial and ethnic disparities. So whether it's my colorectal colleagues, whether it's my thoracic colleagues, whether it's my pediatric surgery colleagues, or again, my plastic and reconstructive surgery colleagues, we've identified racial disparities along racial and ethnic lines. Minority surgeons' service and patient outcomes. So great study from Kamarami et al. It's a little dated from the New England Journal of Medicine. They identified that after controlling for the racial and ethnic makeup of the community, Black and Hispanic physicians cared for significantly more Black and Hispanic patients than did majority physicians. They go on to say that Black physicians cared for more patients covered by Medicaid and Hispanic physicians for more uninsured patients than did white physicians. A more recent study out of PNAS, when looking at physician-patient racial concordance and disparities in birthing mortality for newborns, they open up their statement by saying, we explore concordance in a setting where racial disparities are particularly severe childbirth. In the United States, Black newborns die at 3 times the rate of white newborns. Now, I'm going to let that settle for a second. In the greatest country in the world, which has basically unlimited resources, Black babies die 3 times the rate of white babies. Upon examining 1.8 million hospital births in the state of Florida between 1992 and 2015, newborn physician racial concordance was actually associated with a significant improvement in mortality for Black infants. So it can measure an increase in research and outreach, highlighting minority-specific healthcare needs. So I'm going to use myself as a case report. I am not patting myself on the back by any stretch of the imagination, but what I know that my talks are fairly data heavy, and having the privilege of giving grand rounds around the country, I've recognized that stories, particularly when you've gotten to know somebody, particularly when they come from a historically kind of marginalized group, they can be even more impactful. So I'm just going to tell my basic story as it pertains to my research endeavors and my outreach as a self-identified Black surgeon. So this is me in my white coat at the University of Virginia. This is me pipetting away in Michael Longacre's lab, slaving away in Michael Longacre's lab. This is me obtaining my MPH at Berkeley. I did spend 3 years on the West Coast, which I absolutely adored. This is me as a chief resident at the University of Virginia. This is me as a policy fellow standing next to former Surgeon General Dr. Satcher. And this is me today as an academic plastic and reconstructive surgeon. But my journey, like many of you, started way before. Yes, that's me dribbling basketball. Yes, that's me with hair. I was privileged to play college basketball for 4 years, and it was an amazing time. And one of my teammates, he was actually a year ahead of me, he had keloids on the angle of his mandible. We never, ever chatted about it when he and I were both in college together. I decided I was going to become a pre-med. I was going to college to be an engineer. And then a physician, one of my professors, a majority man, actually pulled me aside and said that you really need to be a physician. You have what it takes. And medicine is really whitewashed, and we need more Black and brown physicians, which I thank that man to this day. So anyway, my teammate had these. He called me doc my sophomore and junior year. He was a senior when he graduated. He called me. I was a general surgery resident. He had heard about me graduating from medical school. He called me and said, hey, doc, I never asked you about this, but what do you know about keloids? And as a general surgery resident, I was starting to contemplate plastic and reconstructive surgery as a field. I very embarrassingly answered. I gave him kind of a medical student answer. Well, keloids grow outside the confines of the original wound, and they have more type 1 collagen than type 3 collagen. But it was a light bulb moment for me that if I was going to be a plastic and reconstructive surgeon, particularly a Black plastic and reconstructive surgeon, I needed to know more. So right around that time is when I decided to go into the lab. I sought out a lab that was doing keloid research, and that's what took me out to Stanford. This was way before texting and social media. I actually had no idea who Dr. Michael Longacre was, but one of the most prolific surgical scientists in plastic and reconstructive surgery. And I remember interviewing with him in the call room. This was just before the 80-hour work week took place in the South. And he said, you should PubMed me. I've got over 100 peer-reviewed publications. I had no idea what he was talking about. This gentleman now has over 1,200 peer-reviewed publications. But anyway, he very kindly brought me into his lab. The gentleman here is the late Dr. George Yang, who was my primary PI, and we studied keloids for 3 years. So many don't know, keloids are innate to human beings. There's no animal model. We are the only species that grow keloids, very interestingly. There's a subset of the porcine family that actually grows them, but they're not exactly the same. So my first project, after writing a literature review pertaining to current research and treatment, was to grow basically a keloid in a petri dish so we could perturb the growth and study it better. And then we started looking, obviously, at keloids at the molecular level, which the vast majority of research today is taking place. So, as plastic surgeons, Dr. Netter, we love show and tell. So fast forward 15 years, I'm now in practice in Philadelphia, and this young man walks into my office, and he had some of the most amazing keloids along the angle of his mandible. I'd never seen it bilaterally, and it was all from shaving. And he came in with his mom. He would always wear a hoodie. And over the course of triple modality therapy and 3 different staged operations, we were able to provide him with this result. Changed his life. His mother wrote me the most kind letter, which I keep on my desk till this day. And I have actually a fairly robust, both in Philadelphia and now in New Haven, keloid practice. And as Dr. Longacre beat into me, it doesn't really happen unless you write it down. So published my experience in Philadelphia along with my partners. So another story. I am what I like to say a praying surgeon, and this was my home pastor. I was privileged to grow up in a fairly affluent Black church in Fairfax, Virginia, right outside of Washington, D.C. And interestingly, the congregation of about 10,000, not many physicians, lots of attorneys, lots of engineers, which is why I wanted to be an engineer. They also drove really nice cars. When I went off to medical school, he would call me not infrequently and ask if I would be willing to serve on the cancer ministry from afar, basically to help break down some of the medical terminology into lay terms for people in the congregation that had been inflicted with various ailments, and particularly cancer. So I remember I had just gotten to Philadelphia. So I was a brand new plastic surgery independent resident, and I was fresh off my policy fellowship, and I was doing some disparity research at that point in time, but was just really excited about being a plastic surgeon. So he said, a woman had just been diagnosed with breast cancer. Can you talk to her? I said, absolutely, Pastor. I was very happy to do it. So I called, spoke with the woman. We talked about her breast cancer diagnosis, and we get to the end of the conversation. And I said, so what kind of breast reconstruction are you getting? And it was silence on the end of the phone. And she said, no one talked to me about breast reconstruction. And so here, this African-American woman who not only was college educated, but had a master's degree, living in the greater DC metropolitan area, had never been informed that she had reconstructive options. So thankfully, we got her to Georgetown, and she was taken care of appropriately and did do very well with her breast reconstruction. But because of my interest in healthcare disparities and now going into the field of plastic and reconstructive surgery, I wanted to dive into this further. So I only identified one paper, 2004, Jennifer Sang, before she became the famous Jennifer Sang at Boston University, while she was at MD Anderson, identified that in Houston, African-American women who had oncologic mastectomies went on to have immediate breast reconstruction at half the rate as majority women. So I was well-versed in national surgical quality improvement data, NSQIP data, and I wanted to know, is this just a DC challenge, or is this a Houston challenge, or is this a national challenge? So we looked at the national experience over the course of 6 years, over 48,000 patients, and identified that there are 2 subsets of the community that don't receive breast reconstruction at the same rate as others. So our more seasoned ladies, no one likes to be called old, right? So our ladies over 45, and then our ladies of color, particularly African-American and Latino women. So then I really started thinking, like, I don't really understand why is this happening? Like, maybe there's a misconception that Black women won't do as well with the operation. And granted, I'm at Penn, which is a microfactory, very similar to here, where we do a lot of autologous breast reconstruction. So I looked at the Penn experience, to identify whether or not the complication profile was any different among Black women relative to white women, and identified the fact that, thankfully, there isn't. There is absolutely no reason that Black women shouldn't receive autologous reconstruction at the same rate as majority women, because the major surgical complication profile and even the medical complication profile are no different. So I had given this talk at the American College of Surgeons Clinical Congress. And I remember very boldly, a gentleman got up to the microphone and he said, "Dr. Butler, that's all well and good, but I can almost guarantee you that these Black and Latino women are living in areas of the country that don't have a lot of plastic surgeons, and/or they have public insurance, not private insurance." And I was kind of stumped because NISQIP data doesn't get that granular. It's just basically 30-day mortality data. But I had the privilege of being equipped with understanding HCUP data, right? Healthcare Utilization Project data, which is state-driven data. I also had just come from my policy fellowship, and I knew that that HRSA, Health Resource Service Administration, identifies where physicians in the country practice and what kind of operations they do. So I picked three very heterogeneous states. I picked Florida, New York, and California, and I cross-referenced them with HRSA data. And what I identified is that Black women who lived in high plastic surgery density areas, so we define that as 3 plastic surgeons per 100,000 population, and had private insurance, still received breast reconstruction at a statistically significant lower rate than white women. So I signed into my deal with Dr. Soletti that if I was to join the faculty there at Penn, that I needed some resources in order to do something about this. I also applied for a Plastic Surgery Foundation grant, an awareness grant, so I could go into underserved communities in the greater Philadelphia area. And we put on a series of what I called Restoring Breast Beauty After Cancer Symposium. So a lot of folks in the community and a lot of folks amongst our medical community recognize the fact that when it came to breast cancer, Black women died at a higher propensity than majority women. Black women were diagnosed at later stages than majority women. Had no understanding of the fact that this reconstruction disparity persisted. So I couldn't go into the community and talk about breast reconstruction disparities without talking about breast cancer. So I took one of the surgical oncologists with me. I took one of my public health advocates and colleagues with me, and we went and we put on these. Additionally, I walked into Dr. Soletti's office and I had this brochure with me. And I said, "Dr. Soletti, with all due respect, if a woman of color comes into our clinic for a breast reconstruction consultation and all she sees are brochures that look like this, it's not the most inviting. Can I have a small budget in order to enhance the optics of our brochures?" And to his credit, in rather short order, we created these. And I think even till this day, I've been gone for a little over 2 years, even till this day, if you go into any of the clinics, you will see these brochures right alongside that prior brochure. Again, in order to show proof of concept about going into community, we did it for 5 years while I was in Philadelphia, and we showed, at least on the short term, that we can enhance that breast health literacy of these communities. And you can see here, these were kind of a pre-symposium survey of these individuals, and this was a post-symposium survey, just assessing, again, their breast health literacy and their breast health acumen. And again, I'm not the only Black and brown academic surgeon in the country that is really proud of the clinical work within my specialty that I do, but also extending that to disparity work. So you have Erica Newman, who's the newly tapped section chief of pediatric surgery at the University of Michigan. You got Fabian Johnson, who is the surgical oncology chief at Hopkins. You got Carrie Ahrens, my good friend, is colorectal. He's now the vice chair of education at Columbia. You got Sharice Berry, who is a trauma critical care surgeon at NYU. My good friend Colin Martin, who's the newly named pediatric surgery chief at WashU, and then your own Estelle Williams, who needs no further introduction. So services, role models, and mentors for the next generation of physicians. So interesting article that looked, and many of you are well versed with this, is the fact that within our field, we are very impactful on our medical students and the disciplines in which they choose. So they identified that exposure to role models in a particular clinical field is strongly associated with medical students' choice of clinical field for residency training. In the ENT literature, and ENT is actually a division within our Department of Surgery at Yale, I was actually sent this by one of my colleagues recently. They looked at factors influencing underrepresented medical students' career choice in surgical specialties. And what they identified was that the fact that female students were more positively influenced by increased exposure to surgical subspecialties, whereas URIM medical students were more positively influenced by race concordant mentorship. My wife is she was a middle school teacher. She's now a middle school counselor. God bless her. She is always pushing me to look deeper into the pipeline as it pertains to much of the work that we do. And this article that she actually brought to my attention looked at the primary influence as to why minorities do not go into the sciences, math, or computer technology is the lack of professional role models or mentors. So I have talked about this a while, and Dr. Williams and I were chatting about the power of mirroring mentorship, the concept that someone needs to see someone that reflects their demographic in order to believe that they can go on to be it. It's incredibly powerful. It's not the end all be all, but it is incredibly powerful. I have taken a lot of pride, particularly when I was in Philadelphia, going into various schools. On the far left, this was me at a high school the year prior to my departure to New Haven. Here, I'm at an elementary school in Northeast Philadelphia. It's a very challenged part of the city. And I purchased a couple of the Operation board games, and I took them in and I talked to them about what medicine was like. And I brought in some surgical caps kind of on a whim. And I got an email actually from that teacher and said, Dr. Butler, you would have thought you gave these students fedoras because they are still wearing their surgical caps. So the power of getting out into the community and mentoring is incredibly powerful. And I have benefited from it. So I considered myself at one point in time this pluripotent stem cell. And I was benefited with the culture medium of really good mentorship and sponsorship from these individuals. And I would be remiss if I didn't comment on the fact that only 2 of them share my intersectional demographic as a Black man, right? Dr. L.D. Britt and Dr. Stephen Stain. I tell my mentees all the time, and I've stolen this phrasing from Wayne Frederick, who is the former president of Howard University, that mentors do not necessarily have to look like you. They just have to share your mission. So again, I have the privilege of going to institutions and talking about diversity, equity, and inclusion efforts and about mentorship. And I would be remiss if I didn't comment on the fact that I benefited greatly from many mentors that did not share my demographic. They just saw something, as they would say, special in me and knew that and felt as if I had what it would take in order to become an academic plastic and reconstructive surgeon. Additionally, you can see my wall of mentors. So Dar Jorgensen was at Roanoke College, Kurt Tribble, a cardiothoracic surgeon at University of Virginia, Michael Longacre, as I mentioned before, at Stanford, George Yang at Stanford, L.D. Britt, chair at EVMS in the great Commonwealth of Virginia, Joe Sterletti, my chief at University of Pennsylvania, Joe Beiske, the current CEO and director of the American Board of Surgery, and Steve Stain, who is about to be president of American Surgical, who's also served as a phenomenal mentor as it pertains to leadership attainment. I glean something different from all of these individuals, and I say that it is necessary in all aspects of life, both professional and personal, that your mentorship comes from disparate groups. I also believe that it's really important that mentorship does not all come from the same person, because that could be a recipe for disaster. So the concept of mosaic mentorship, I'm a huge fan and proponent of, and could give a talk just on that concept. So URM patients have improved perception of the care. The optics matter. Interesting article recently out of JAMA Open, where they looked at 4-year cross-sectional analysis of over 117,000 press gaining patient surveys. They looked at the physician surveys of physicians among ethnically discordant patient-physician dyads. They had significantly lower odds of receiving the maximum patient experience score. So Black and Asian patients in particular were associated with lower patient experience ratings. So they summarized delivery of healthcare in a culturally mindful manner between racially ethnic discordant patient-physician dyads is essential. Efforts to improve physician workforce diversity are imperative. As it pertains to clinical trials, we have seen this bore out. really good study from Karen Butler when she was in Cincinnati. They identified that African Americans were more likely to participate in a clinical trial if just a single member of that clinical trial investigative team came from minority background. They continued, they also summarized that the continued effort to recruit and train African American investigators must be a priority. This bore out during the pandemic when we were about to roll out the COVID-19 vaccine. Many of us were not overly surprised that there was a slow uptake within the Black and Latino community as it pertained to who was going to get vaccinated. It was a frequent conversation in Philadelphia, actually. And I think to Moderna and Pfizer's credit, everybody knew Dr. Fauci. They got Dr. Fauci. They asked Dr. Fauci if he would also amplify the work that this amazing scientist had put forth in helping to create the Moderna vaccine in particular, Dr. Kizzmekia Corbett. And I think in rather short term, they were able to increase the amount of Black and Brown and Latino representation within the clinical trial that actually met the national demographic. So as it pertains to the workforce, I had given a workforce talk at the American College of Surgeons Clinical Congress. I had just finished my general surgery residency, and Dr. Tarpley, I'm not sure if many of you know Dr. Tarpley, very strong Southern accent from Emory. No, from Vanderbilt, I apologize. Dr. Tarpley does a lot of global work, and he got up to the podium and he said, Dr. Butler, that's all well and good, but how do you propose we rectify this problem? And that phrase from many years ago now has stuck with me because I really believe that we need to take healthcare disparities research beyond the description and move it into action. We need to propose interventions. We need to study them. We need to publish on them. And even those that are unsuccessful, we should still publish those so we don't have people waste their time chasing interventions that don't bore out. So when I took the faculty role at the University of Pennsylvania in 2015, simultaneously, I was asked to come into the GME office to help with minority recruitment. And as I look at the pipeline, and I know that this phrasing is challenging, particularly in the Indigenous community now, but this actually we've pulled from a paper. So this leaky pipeline concept is something that I spent a lot of time thinking about as it pertains to how you can stop some of the leaks in the pipeline. Now, my privilege as now a newly tapped academic plastic surgeon at the University of Pennsylvania and also in the GME office and also an associate program director, I didn't have a whole lot of say over the medical student recruitment, and I didn't have a whole lot of say in the faculty recruitment, but I had a whole lot of pull as it pertained to the recruitment of residents. So I went to the DIO, the designated institution official, George Burns at the University of Pennsylvania, and I said, we need to come up with an approach. So we launched what we call the three-prong approach to improving racial and ethnic diversity among our residents at the University of Pennsylvania Health System. So implemented a visiting clerkship program, implemented holistic review, and targeted outreach to these communities. So our visiting clerkship program, and I believe something is very similar here at the University of Washington. Basically, it was a scholarship, 4-week summer internship, and we gave the carrot of a scholarship, a $1,500 stipend to entice them to come to the University of Pennsylvania. Additionally, we gave them a resident and faculty mentor, which I think is absolutely pivotal when starting these programs to make sure that these young people that you bring to your campus are supported. I ensured that they had a meeting with the program director or the chair, so they got appropriate exposure. We had a welcome gathering and end of rotation in order to help enhance community. And we very intentionally made it funded by the individual departments, so they had greater teeth. It wasn't something that was being levied necessarily by the health system at large or by the School of Medicine. So you can see we started the program 2015, 2016. I could only convince 4 training programs to take it on. General surgery and very proudly plastic surgery was one of those 4. The blue bars are the number of disciplines. The orange bar, the number of students that rotated with us during that period of time. Couldn't have any rotators in 2020, 2021 because of the height of the pandemic. But we picked up with steam right after, 17 disciplines, 60 individuals that rotated with us over the course of the 2022 year, which was my last year at Penn. Holistic review, many of you are well versed with it, so I'm not going to belabor. But there's this concept as it pertains to how we assess candidates and medical students for residency of first looking at the metrics, then looking at the attributes, then looking at the experiences. The AAMC in 2010, when they were looking at how to enhance the enrollment of students into medical school that came from diverse backgrounds, they recommended flipping the MAE to EAM. So first looking at experiences, then looking at attributes, and then looking at their metrics. So thankfully, there was a lot of buy-in from our residency program directors kind of across the health system as it pertained to that. And then targeted outreach. So at the University of Pennsylvania, there's an organization that was founded by an emergency medicine physician, a Latina woman who's full professor called the Alliance of Minority Physicians. What she recognized was the fact that even preceding me, Penn was good at bringing a couple of residents into the health system, but many of them, a couple of residents from diverse backgrounds into the health system, but they felt kind of siloed. There was one in radiology, there were two in surgery, there was one in ortho, and she built a infrastructure where these residents and junior faculty could get together for building community, for professional development activities, for having tough conversations about self-promoting when it came to being promoted. And we tapped into this group to help us with our recruitment efforts. We recruited both before, during, and after, and again, to these young people to ensure that they knew that we really wanted them. So how do we do? So you can see here, we instituted the program in 2016. The blue bar graph is our representation of UIM candidates that received interviews and actually interviewed. The blue bar graph is our representation of UIM newly matched interns. And you can see with some intentionality over the course of those 6 years, we increased our UIM representation from 9.1 to 32.4%. In order to kind of demystify this misconception that you have to jeopardize the competitiveness of your program in order to become more diverse, we proved that that was absolutely not the case. So I continue to track USMLE Step 1 scores as we put this initiative into place and revealed no statistically significant difference in their Step 1 scores. I also wanted to identify whether programs had to go further down a list in order to have a more diverse pool, and also showed that their mean maximum rank number was no different. So we published this in Annals of Surgery. We called it, leading from the front, as the surgeons like to do. And I wanted to look very specifically at plastic surgery because I showed you earlier data that us plastic surgeons have some of the most significant challenges as it pertains to diversifying our workforce. And you can see we started in 2016 with the program, and I very intentionally put female representation and UIM representation. And the reason for that is because there's also a misconception that in order to enhance your diversity of your race ethnicity, you have to somehow jeopardize the representation of your gender. And I wanted to show that, again, with intentionality, the blue bar is our gender representation, the yellow bar is our UIM representation, is that we were able to enhance both simultaneously. So this picked up steam throughout the entire health system. Everybody wanted to know what was surgery doing, and our DIO presented it to internal medicine and radiology and pediatrics. And when we implemented this three-prong approach kind of throughout the entire health system, we tripled our UIM representation of our newly matched interns throughout the entire health system, which made our dean and made our CEO and our CMO quite happy. It's really hard to get things published in academic medicine. I've tried for years. So just recently, we were able to get this experience published in academic medicine very proudly. So I decided to transition a little further north. It is definitely colder in New Haven than Philadelphia. They lied to me. I was recruited in to be their inaugural vice chair of diversity, equity, and inclusion and help build their breast reconstruction practice at Yale. And when I came to Yale, I was like, man, I was really fortunate to be able to make some significant strides in Philadelphia. Can we replicate this in New Haven? So we launched our three-prong approach. So this is what I inherited. So I came in 2022, and you can see here, this is our representation of newly matched interns. So we had a banner year in 2020, or they had a banner year in 2020, where 50% of their newly matched interns were women. But it kind of hovered right around 30%. As it pertained to UIM representation, it never gotten to 20%, kind of hovered in the kind of 10 to 15 range. So launched a three-prong approach, very intentional about getting front and center. We did some additional webinars in addition to in-person gatherings. And I can very proudly say this past March, we increased our female representation by a rather significant amount, and our UIM representation was an all-time high for Yale's Department of Surgery. This is my favorite slide of the entire talk. I am really blessed to be able to teach and educate some of the most bright. Now, you have some really bright residents here, don't get me wrong. But I am beholden to these young folks. They're incredibly bright. They are incredibly hardworking. They are incredibly collegial with each other, and they just so happen to come from really diverse backgrounds. And I couldn't be more proud of what we matched in this past March. So promising early results, but in my opinion, there's still work to do, and we cannot stop now. So as I mentioned earlier, DEI is under siege. There's articles that are coming out literally on a weekly basis at this point in time as it pertains to vilifying the concept of diversity, equity, and inclusion. Most recently, just last week, CNN Business said that, Cornell donor, a sizable Cornell donor, demanded that the president step down, citing toxic diversity policies. So a couple take-home messages as I kind of finish up. As it pertains to moving this forward, I refuse to be muted. I am very careful with my language and the vernacular that I use. As it pertains to what we collectively should consider, if we take the politics out of it, whether it's right-leaning or left-leaning, whether it's red or blue, I think we will gain so much more as it pertains to the conversation, our willingness to engage in the conversation, to not shut down conversation, for people to feel as if we are all invited to the conversation. Stick to the data. So it has been incumbent upon me, and I've showed you a lot of data. I felt it's been incumbent upon me for the last 20 years to show data, to show why this is necessary, whether it's disparity data as it pertains to the clinical enterprise, whether it's disparity data as it pertains to workforce. What I have found is that some of the naysayers to DEI work, they use lots of conjecture. Oh, well, during my day or where I was, it was really diverse, or, I knew that one Black or brown physician, and they would be appalled that you all are considering that. It dismisses and minimizes their assent, and it's not data-driven at all. So if you look at the data, it's almost undisputable that we need to continue to move this forward in a responsible way. It's not a zero-sum game. Again, we are in the greatest country in the world with seemingly unlimited resources. So it's not about if this group gets it, the other group does not. It's about lengthening the table, and we will all benefit from this push towards inclusive excellence. And then, as Dan Dent had stated, keeping it patient-centered. So I can't give a DEI talk in the month of February without having a Dr. Martin Luther King Jr. quote. Just wouldn't be right. I've got lots of great quotes by that came from Dr. King. This is one of my favorites. It says, "The arc of the moral universe is long, but it bends towards justice." Now, I don't have the credentials to ever critique anything that Dr. King said, but if he would so kindly allow me to add to his statement, I would say, yes, Dr. King, but it doesn't bend on its own. So I recognize that I have the privilege of being a Black male academic plastic and reconstructive surgeon at a fairly prominent institution. So I have a platform, and I have that privilege. And what I do with that platform and that privilege is that I write about it, and I do research about it, and I give talks about it. And I would ask you all that if you continue to care about diversity, equity, and inclusion, that you consider using your privilege, use your platform, because we all have one, particularly within the confines of this room. So with that, I will close. I thank you so very much for the privilege of the podium. I thank you so very much for bringing me here to UW, and I'm happy to answer any questions that you have.